Welcome to the Deep Dive, where we take a stack of information and extract the most important nuggets of knowledge and insight for you. Today, we're embarking on a fascinating journey into the Diagnostic and Statistical Manual of Mental Disorders. Fifth edition, you might know it as the DSM-5. Think of this as your shortcut to understanding the complex, nuanced world of mental health diagnoses.
Exactly. Our source material today is incredibly clear and concise, guiding us through the fundamental concepts and key diagnostic categories of the DSM-5. Our mission is really to demystify these classifications, highlight the crucial distinctions, and help you grasp not just what these disorders are, but the detailed criteria used for their identification. And more importantly, why those details matter.
I love that why those details matter. Okay, let's unpack this. We're going to cover everything from how the DSM-5 is structured to the specific, sometimes, well, surprising criteria for a wide range of conditions. We want to ensure you walk away with a truly well-informed perspective, ready to connect the dots yourself. So, to kick us off, how does the DSM-5 actually work? I know it uses what's called a categorical approach, right? Dividing mental disorders into types, each defined by a set of symptoms.
That's right. What's truly insightful about this categorical approach is that while it defines distinct types, it also accounts for heterogeneity. This means an individual only needs to present with a subset of symptoms from a larger list. So as a result, two different people could actually have somewhat different symptom profiles, but still receive the same diagnosis. It highlights the vast spectrum within each condition.
Right. And a big shift in the DSM-5 was moving to a non-axial assessment system, wasn't it? What was the thinking behind that change? How does it impact things? That's a great question because it's a fundamental shift. Think of it this way. Instead of separate sort of tiered lists for mental, physical, and psychosocial factors, the DSM-5 now views everything more holistically. All mental and medical diagnoses are listed together, with the primary diagnosis coming first. It basically acknowledges that mental health isn't separate from physical health or, life circumstances. Psychosocial and contextual factors are indicated separately using ICD codes, those are the International Classification Codes for Diseases, and the level of disability is assessed using something like the World Health Organization Disability Assessment Schedule, or another appropriate measure. The DSM-5 then organizes all of this into 19 distinct diagnostic categories.
Okay, 19 categories. So we've talked about the big picture of the structure. Let's zoom in on our first major category, neurodevelopmental disorders. These are fascinating because they're typically apparent before a child even starts grade school and cause real impairment in personal, social, or academic functioning. Absolutely. The first one we'll look at is intellectual disability. Now, this diagnosis isn't just about an IQ score, which is a common misconception. It requires three key criteria that paint a broader picture. First, there must be significant deficits in reasoning, problem-solving, and abstract thinking, confirmed by both a clinical assessment and a standardized intelligence test. People typically score around 70 or less on such a test, which indicates a measurable difference in cognitive abilities compared to most people.
So it's not just a number. And the second criterion sounds equally important. Deficits in adaptive functioning that prevent meeting community standards of independence and social responsibility. This impacts at least one of three specific domains across multiple environments.
Precisely. Those domains are conceptual things like reading, writing, math skills. Social, which covers interpersonal communication, judgment, empathy, and practical daily living skills like personal hygiene, money management, self-care. It's really about how someone navigates the world independently.
And the third piece is that the onset of these deficits must occur during the developmental period, childhood, or adolescence. What's really crucial here, it seems, is that the DSM-5 distinguishes 4 degrees of severity: mild, moderate, severe, and profound, not based on just IQ, but on the person's adaptive functioning in those domains you just described. That's a huge distinction, isn't it?
It truly is. It emphasizes that real-world functioning, not just a test score, defines the severity. Building on that idea of early development, let's turn to autism spectrum disorder, or ASD. This requires persistent deficits in social interaction and communication, along with restricted, repetitive patterns of behavior, interests, and activities.
I think many people have a general idea of ASD, but can you give us some specific examples? What do those social interaction and communication deficits actually look like?
Sure. In social interactions, you might see abnormalities in eye contact, gestures, facial expressions. Individuals may seem sort of oblivious to others or maybe not initiate social interactions. In terms of speech, there can be delayed or atypical language. Things like pronoun reversal, saying you want to go when they mean I want to go, or echolalia, which is repeating words or phrases they've heard, sometimes like an echo.
Okay. And for those restricted, repetitive behaviors,
Yeah.
what are some classic examples that, stick out?
We're talking about things like preoccupations with narrow interests or maybe parts of objects, repetitive body movements like arm flapping, or activities like compulsively switching lights on and off, spinning toy car wheels, or meticulously lining up blocks. For diagnosis, these symptoms must be present during the early developmental period and cause significant impairment in functioning.
Right. Finally, in this category, we have attention deficit hyperactivity disorder, or ADHD. It's often misunderstood, I think, as just kids being hyper, but the DSM-5 helps us see it's more about a neurological difference, right?
Hmm.
In the brain's ability to regulate attention, impulsivity, activity. How does the DSM-5 capture that?
That's a perfect way to put it. The diagnosis requires a significant number of symptoms related to inattention, like difficulty sustaining focus or being easily distracted, and/or symptoms of hyperactivity impulsivity, such as constant fidgeting, interrupting others, or difficulty waiting their turn. The exact number of symptoms needed varies slightly by age, but the key is that these symptoms significantly impact daily life.
And what are the critical criteria for diagnosis beyond just the symptoms themselves? Are there time frames or settings involved?
Yes, exactly. A crucial detail is that some symptoms must be present before 12 years of age, last at least 6 months, and be apparent in at least two different settings, such as at home and at school. This isn't just a challenge in school, it affects self-management, relationships, even job performance throughout life. It highlights the hidden complexities behind behaviors we might just casually label. The DSM-5 defines three presentations: predominantly inattentive, predominantly hyperactive impulsive, and combined presentation.
Okay, so we've explored disorders that often emerge early in life, deeply impacting development. Now let's shift our focus a bit. Let's talk about conditions that can dramatically alter an individual's perception of reality, often emerging in adolescence or early adulthood. This brings us to the fascinating and, well, often misunderstood realm of schizophrenia spectrum and other psychotic disorders.
Right. The diagnosis of schizophrenia itself requires two or more active phase symptoms. These include delusions. Those are firmly held false beliefs, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms, which mean a reduction or absence of normal functions. And critically, at least one symptom must be delusions, hallucinations, or disorganized speech. What's truly insightful here is how these symptoms don't just change perceptions, but fundamentally reshape a person's entire reality. Everyday life can become almost unrecognizable, which is why early, accurate diagnosis is so vital.
That makes the duration criteria sound incredibly important then.
Yeah.
How long do these signs need to be present for a schizophrenia diagnosis?
There must be continuous signs of the disorder for at least 6 months. So, for example, a person might have prominent active symptoms for, say, 1 month, followed by less severe symptoms, or maybe just negative symptoms for at least 5 months after that. Also, the person's level of functioning must be markedly below their pre-onset level, significant decline.
And this raises an important question that I think many listeners wonder about. How do other related disorders like schizophreniform and brief psychotic disorder differ from schizophrenia? Where do clinicians draw that line?
The main distinction here is simply time, duration. While the symptoms might feel very similar to schizophrenia, schizophreniform disorder symptoms last at least 1 month, but less than 6 months. And for brief psychotic disorder, the symptoms are present for at least one day, but less than 1 month. So it really emphasizes how crucial duration is in understanding these conditions, even when the symptoms themselves seem similar.
Makes sense. Okay, from these shifts in reality, let's move to the powerful fluctuations in mood, specifically in bipolar and related disorders. The diagnosis here involves looking at a client's history in terms of three key mood episodes: manic, hypomanic, and major depressive. Can you break down what defines a manic episode?
Absolutely. A manic episode involves a persistent and abnormally elevated, expansive, or irritable mood, along with persistently increased energy and goal-directed activity, a real upswing. These symptoms must last at least 1 week and cause marked impairment in functioning, or require hospitalization, or include psychotic symptoms. It's often a significant and disruptive period.
Okay. And how is a hypomanic episode different from a full manic episode? What are the key distinctions there?
It's similar to a manic episode in terms of the elevated mood and energy, but the required duration is shorter, at least 4 consecutive days. And crucially, the symptoms do not cause marked impairment, don't require hospitalization, and don't include psychotic symptoms. It's a less severe, though still significant, shift from baseline.
Gotcha. And then we have the major depressive episode, which, as the name suggests, often involves a profound low.
Precisely. A major depressive episode involves either a depressed mood or a loss of interest or pleasure in nearly all activities. That's called anhedonia. Plus other symptoms like insomnia or hypersomnia, psychomotor changes, that's either agitation or slowing down of movement-impaired concentration, feelings of worthlessness or excessive guilt. These must last at least 2 weeks and cause significant distress or impaired functioning.
It sounds like diagnosing bipolar I and II could be tricky then, given these different episodes. What's the core difference between bipolar I and bipolar II disorder?
It can be a little confusing because of the overlap. The key difference is the mania. Bipolar I disorder requires at least one manic episode. That full-blown episode we just described, it may or may not have been preceded or followed by major depressive or hypomanic episodes. The presence of even one full manic episode is enough for a bipolar I diagnosis. In contrast, bipolar II disorder requires at least one hypomanic episode and at least one major depressive episode. The full-blown manic episode isn't present in bipolar II.
Okay, that clarifies it. And then there's cyclothymic disorder. How does that fit into this spectrum?
Cyclothymic disorder involves numerous periods of hypomanic symptoms that don't quite meet the full criteria for a hypomanic episode, plus numerous periods of depressive symptoms that also don't meet the full criteria for a major depressive episode. This up and down pattern must last for at least 2 years in adults or 1 year in children and adolescents. It's a chronic, fluctuating mood disturbance, but generally less severe than bipolar I or II.
Right. Now, to the depressive disorders themselves, which include major depressive disorder and persistent depressive disorder. Major depressive disorder requires at least one major depressive episode, as we just discussed. What's particularly insightful about how these symptoms can manifest across different age groups? Does depression look the same in kids and adults?
That's a critical point because depression isn't one size fits all. Absolutely not. In children, depression might show up more as separation anxiety or just general irritability, maybe somatic complaints. For adolescents, aggression and antisocial behaviors can actually be prominent, sometimes leading to a misdiagnosis of conduct disorder when it's really underlying depression. In older adults, symptoms can involve hopelessness, insomnia, decreased appetite, and prominent cognitive impairments like memory issues, making it hard sometimes to distinguish from a mild neurocognitive disorder. It really underscores the importance of a thorough assessment.
Wow, yeah. And how does persistent depressive disorder differ from major depressive disorder then?
Persistent depressive disorder, also known sometimes as dysthymia, requires a depressed mood plus at least 2 additional symptoms, but for a much longer duration, at least 2 years in adults or 1 year in children and adolescents. The key is its chronic, long-lasting nature, even if the symptoms aren't always as intense as a major depressive episode. It's a more enduring, low-grade depression.
Okay, let's shift gears and dive into the anxiety disorders. These disorders go far beyond everyday worries, right? They're characterized by fear and anxiety so intense they genuinely interfere with daily life, sometimes even leading to physical symptoms like a racing heart or dizziness. We'll touch on separation anxiety disorder, social anxiety disorder, panic disorder, agoraphobia, and generalized anxiety disorder.
Right. Starting with separation anxiety disorder, this isn't just a child being clingy. It involves developmentally inappropriate and excessive fear or anxiety related to separation from home or from attachment figures. Symptoms must be present for at least 4 weeks in children and adolescents or 6 months in adults. Children might refuse to go to bed or school without someone close by, or complain of physical symptoms like headaches or stomach aches when facing separation. It often develops after a life stressor, and it can be profoundly disruptive for families.
And what's the core fear in social anxiety disorder? It's more than shyness, right?
Oh, absolutely. The essential feature is intense fear or anxiety about one or more social situations where the person might be scrutinized by others. They have this deep fear of negative evaluation. This leads them to either avoid these situations entirely or endure them with intense fear and discomfort. It's far more than just being shy. It's a debilitating fear of judgment that can really limit someone's life.
Panic disorder is something many people have heard of, but what specifically defines a panic attack in the diagnostic sense, and what characterizes the disorder itself?
Okay, so a panic attack is a sudden, intense surge of fear or discomfort that reaches a peak within minutes. Symptoms include things like heart palpitations, trembling, shortness of breath, feeling dizzy or nauseous, and often an overwhelming fear of losing control or even dying. It feels catastrophic. Panic disorder is then characterized by recurrent, unexpected panic attacks, meaning they seem to come out of the blue. And at least one attack has to be followed by 1 or more months of persistent concern about having additional attacks or their consequences, or by a significant maladaptive change in behavior related to the attacks. For example, someone might start avoiding places where they had an attack, or fear losing their job due to attacks, maybe even self-medicate with alcohol. And it's critical, really critical, to rule out medical conditions like hyperthyroidism or heart problems before diagnosis because the physical symptoms are so prominent.
Agoraphobia is another term that's widely used, but maybe often misunderstood. What situations does it typically involve, and what's the underlying fear driving it?
Agoraphobia involves marked fear or anxiety about at least 2 of 5 specific situations: using public transportation, being in open spaces like parking lots, being in enclosed spaces like shops or theaters, standing in line or being in a crowd, and being outside the home alone. The crucial point is that the person fears or avoids these situations because they believe escape might be difficult, or help might not be available if they were to have panic-like symptoms or other incapacitating or embarrassing symptoms. So people with agoraphobia may increasingly restrict the places they're willing to go, sometimes even becoming housebound.
And finally, generalized anxiety disorder, or GAD. How do we differentiate that from everyday worry, which, let's face it, we all experience?
That's the key distinction. GAD involves excessive anxiety and worry about multiple events or activities, work, school, health, family, occurring more days than not for at least 6 months. The targets of worry can be age-related, kids worrying about school performance, older adults may be worrying more about health. But it's important to distinguish GAD from non-pathological anxiety because GAD anxiety is experienced as very difficult to control. It feels pervasive. It's often out of proportion to the actual likelihood or impact of the feared event, and it's more likely to be accompanied by physical symptoms like fatigue, muscle tension, restlessness, difficulty concentrating, sleep problems, nausea. It's really the pervasive, uncontrollable nature of the worry that's key, along with the physical symptoms.
It's interesting how OCD, obsessive-compulsive disorder, is now in its own category in the DSM-5, separate from anxiety disorders. It's grouped with disorders like body dysmorphic and hoarding disorder. What defines OCD?
Right, that was a significant change. OCD is characterized by the presence of recurrent obsessions and or compulsions that are time-consuming, say, take up more than an hour a day or cause significant distress or impairment in functioning. Obsessions are those disturbing, unwanted, intrusive recurrent thoughts, images, or urges that the person tries to ignore or suppress, often unsuccessfully. Compulsions are repetitive behaviors like hand-washing or checking, or mental acts like praying or counting that the person feels driven to perform, often in response to an obsession or according to rigid rules. The goal is often to prevent or reduce anxiety or to distress or prevent some dreaded event, but they're either not connected realistically or are clearly excessive, like compulsively checking appliances dozens of times due to an obsessive fear of fire. The core is that cyclical pattern, the intrusive thought or obsession, and the driven behavior or compulsion to try and neutralize it.
Okay, now let's turn to trauma and stressor-related disorders, which include PTSD, acute stress disorder, and adjustment disorders. These really highlight how profoundly life events can impact our mental well-being.
Absolutely. Post-traumatic stress disorder, PTSD, follows exposure to actual or threatened death, serious injury, or sexual violence. Either experiencing it directly, witnessing it, learning it happened to someone close, or repeated exposure to aversive details like first responders. Symptoms must last more than 1 month and cause significant distress or impairment. The DSM-5 provides separate criteria for different age groups, but they all involve symptom categories like intrusion, distressing memories, nightmares, flashbacks, avoidance trying to avoid thoughts, feelings, or external reminders of the trauma, negative changes in cognition and mood like persistent negative beliefs, fear, guilt, detachment, and marked changes in arousal and reactivity like irritability, hypervigilance, sleep problems, being easily startled. It's the lasting, pervasive impact of the trauma.
So what's the key difference then with acute stress disorder? How do clinicians make that distinction when the initial symptoms might seem so similar right after an event?
The primary difference, and it's a critical one for understanding the immediate aftermath and potential intervention, is the duration of symptoms. For acute stress disorder, the required duration is shorter. Symptoms occur and resolve within the period of 3 days to 1 month following the trauma exposure. It also requires exposure to the same types of traumatic events, followed by symptoms representing 5 categories: intrusion, negative mood, dissociation, like feeling detached or unreal, avoidance, and arousal. It's essentially capturing the immediate, intense reaction to trauma before it potentially becomes chronic PTSD. If symptoms persist beyond a month, the diagnosis might shift to PTSD.
Right, okay. And then there are adjustment disorders. These sound like they cover a broader range of stressors, maybe less severe than those causing PTSD.
They do. Adjustment disorders involve the development of emotional or behavioral symptoms in response to one or more identifiable psychosocial stressors. Could be a single event, like ending a relationship, or multiple stressors, like business difficulties and marital problems. These symptoms must be clinically significant, meaning they cause distress that's out of proportion to the severity of the stressor, or they cause significant impairment in social, occupational, or other important areas of functioning. They have to develop within 3 months of the stressor's onset and typically remit within 6 months after the stressor or its consequences have terminated. It's about a disproportionate or maladaptive reaction to a common life stressor that significantly impacts functioning but doesn't meet criteria for another disorder like MDD or PTSD.
We often hear about the mind-body connection, and that seems particularly relevant for somatic symptom and related disorders. What does somatic symptom disorder involve exactly?
With somatic symptom disorder, imagine someone who experiences one or more physical symptoms. It could be pain, fatigue, gastrointestinal issues, something else that are very distressing or cause significant disruption in daily life. And critically, they also have excessive thoughts, feelings, or behaviors related to those somatic symptoms or associated health concerns. This might manifest as persistent thoughts about the seriousness of one's symptoms, high levels of health-related anxiety, or spending excessive time and energy devoted to these symptoms or health concerns. People with this disorder often constantly worry about their health, spend a great deal of time researching symptoms, and may seek care from multiple doctors. Even if they do have an actual medical condition causing the symptoms, their level of concern and preoccupation is excessive. It's not about faking symptoms, the distress is real. It's about the overwhelming psychological focus on the physical sensations.
That sounds like it could be confusing to distinguish from other things. So how is that different from illness anxiety disorder? Is that the same as hypochondria used to be?
It's related to what used to be called hypochondriasis, yes. Here's where it gets really interesting, the distinction. People with illness anxiety disorder have no actual significant physical symptoms or only very mild symptoms. However, despite the lack of symptoms, they are preoccupied with having or acquiring a serious medical illness. They're constantly checking their body for signs of illness, easily alarmed about their health status, convinced something serious is lurking. Like those with somatic symptom disorder, they often perform extensive health-related behaviors like researching or doctor visits. But sometimes their fear might also lead to maladaptive avoidance behaviors, such as not visiting sick friends or avoiding hospitals, fearing they'll catch something. The key distinction is the presence, somatic symptom disorder, or relative absence, illness anxiety disorder, of significant physical symptoms, while both share that high health anxiety and preoccupation.
Okay. And factitious disorder is another one that might raise eyebrows. What exactly is that? Is that faking illness?
Factitious disorder involves the falsification of physical or psychological signs or symptoms, or induction of injury or disease associated with identified deception. Someone is essentially pretending to be sick, or making themselves sick, or making someone else sick. Factitious disorder imposed on another, previously Munchausen by proxy. For example, someone might report feeling suicidal after a spouse's death when the spouse didn't actually die, or they might inject themselves with bacteria to produce an infection. The crucial distinguishing factor here is the motivation. The person engages in this deceptive behavior even in the absence of obvious external incentives like financial gain or avoiding work. The motivation is presumed to be internal, the desire to assume the sick role to get attention or care. This is what separates it from malingering.
What exactly is malingering then, since that's often confused with factitious disorder? You hear that term thrown around.
Right. Malingering, while not a formal mental disorder diagnosis itself in the DSM-5, but rather a condition that may be a focus of clinical attention, is the intentional production of false or grossly exaggerated physical or psychological symptoms. But here, the motivation is clearly for an external reward or gain. Things like avoiding military duty or work, obtaining financial compensation like disability payments, evading criminal prosecution, or obtaining drugs. It should be suspected when there's a clear discrepancy between the person's claimed stress or disability and objective findings, or maybe a lack of cooperation during evaluation, or the presence of antisocial personality disorder. The goal is external gain, unlike the internal motivation in factitious disorder.
Right, that distinction is key. Okay, moving on to eating disorders, which are complex and often misunderstood. Let's start with anorexia nervosa. What are its core features?
For anorexia nervosa, the essential features are, First, a restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is key. Second, there's an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, even though they're already underweight. And third, there's a disturbance in the way one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or a persistent lack of recognition of the seriousness of their current low body weight. It has two main subtypes. The restricting type, where weight loss is achieved primarily through dieting, fasting, or excessive exercise, and the binge-eating purging type, where the person has also engaged in recurrent episodes of binge-eating or purging behavior like self-induced vomiting or misuse of laxatives. It's a condition with potentially severe medical consequences.
And bulimia nervosa, how does that typically present and how does it differ from anorexia?
Bulimia nervosa involves recurrent episodes of binge eating. A binge is defined as eating in a discrete period of time, like within any 2-hour period, an amount of food that is definitely larger than what most individuals would eat in a similar period under similar circumstances. And there's a sense of lack of control over eating during the episode. These binges are followed by recurrent, inappropriate compensatory behaviors to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. These binge eating and compensatory behaviors both occur, on average, at least once a week for 3 months. Crucially, self-evaluation is unduly influenced by body shape and weight. And unlike anorexia nervosa, the disturbance does not occur exclusively during episodes of anorexia nervosa, and the individual is typically not significantly underweight. They're usually normal weight or overweight. Binges are often triggered by things like interpersonal stress, negative feelings related to body weight or food, or a dysphoric mood.
Okay. Next, we have disruptive impulse control and conduct disorders, which often involve behaviors that impact others or violate social norms. Can you clarify the distinction between oppositional defiant disorder, ODD, and conduct disorder? They sound similar.
They can seem similar, but there's a key difference in severity and the nature of the behaviors. ODD's essential feature is a recurrent pattern of an irritable mood, argumentative defiant behavior, or vindictiveness. You need at least 4 symptoms from these categories exhibited during interactions with at least one individual who isn't a sibling. Things like losing temper, being easily annoyed, arguing with authority figures, actively defying requests, deliberately annoying others, blaming others, being spiteful or vindictive. This pattern must last at least 6 months and cause distress to the individual or others in their immediate social context, or negatively impact functioning. It's characterized by that defiant, uncooperative, hostile stance, primarily towards authority figures. Conduct disorder, on the other hand, involves a more severe, repetitive, and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated. Symptoms fall into 4 main categories: aggression to people and animals, like bullying, fighting using weapons, cruelty; destruction of property, like fire setting or vandalism; deceitfulness or theft, like lying, shoplifting, breaking into houses; and serious violation of rules, like staying out late, running away; truancy. It's a more serious pattern of antisocial behavior. And it's important to note this diagnosis cannot be assigned to individuals over 18 who meet the criteria for antisocial personality disorder, as conduct disorder in childhood or adolescence often precedes an ASPD diagnosis in adulthood.
Right, that makes sense. And finally, a category that impacts so many lives: substance-related and addictive disorders. This includes substance use and substance-induced disorders for 10 classes of substances. How does a DSM-5 characterize a substance use disorder? Is it just about using a lot?
It's more complex than just quantity or frequency, though those play a role. A substance use disorder is characterized by a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite significant substance-related problems. It requires at least 2 characteristic symptoms occurring within a 12-month period, causing clinically significant impairment or distress. These symptoms are generally categorized into 4 groups. Impaired control, this includes things like using more substance or for longer than intended, persistent desire or unsuccessful efforts to cut down or control use, spending a great deal of time obtaining, using, or recovering from the substance, and craving. Social impairment, like recurrent use, resulting in a failure to fulfill major role obligations at work, school, or home. Continued use, despite persistent social or interpersonal problems caused or exacerbated by the substance. Giving up important social, occupational, or recreational activities because of use. Risky use, this means recurrent use in situations in which it is physically hazardous, like driving impaired. Continued use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. And pharmacological criteria, which include tolerance, meaning needing markedly increased amounts of the substance to achieve intoxication or desired effect, or a markedly diminished effect with continued use of the same amount. And withdrawal, which is experiencing the characteristic withdrawal syndrome for the substance, or taking the substance, or a closely related one, to relieve or avoid withdrawal symptoms. Basically, it's about a pattern of use that creates significant problems across multiple areas of a person's life.
And there are also substance-induced disorders. What distinguishes those from a substance use disorder?
Yes, substance-induced disorders are distinct. These include conditions like substance intoxication, substance withdrawal, and various substance medication-induced mental disorders, like substance-induced psychotic disorder or depressive disorder or anxiety disorder. These disorders share common characteristics. Their symptoms resemble those of an independent mental disorder, but there's clear evidence from the history, physical exam, or lab findings that the symptoms develop during or soon after, usually within 1 month of, substance intoxication or withdrawal, or after exposure to a medication. And the involved substance medication is capable of producing the mental disorder. They also can't be better explained by an independent mental disorder that just happens to co-occur, and they cause clinically significant distress or impairment. It's a direct, often acute effect of the substance on the brain and behavior.
Okay. We're moving on now to neurocognitive disorders, which involve impaired functioning in one or more of these 6 key cognitive domains: complex attention, executive function, learning and memory, language, perceptual motor, and social cognition. And importantly, this represents a decline from a previously attained level of functioning, which is a crucial part of the definition, right? It's a change.
That decline from a previous level is indeed critical. That's what distinguishes these from, say, lifelong intellectual disability. Delirium, for instance, requires a disturbance in attention, like reduced ability to direct, focus, sustain, and shift attention, and awareness, reduced orientation to the environment, plus an additional disturbance in cognition, like memory deficit, disorientation, language, visuospatial ability, or perception. The key is that these symptoms develop over a short period, usually hours to a few days, represent a clear change from baseline attention and awareness, and tend to fluctuate in severity during the course of a day. And there must be evidence from the history, physical exam, or labs that the disturbance is a direct physiological consequence of another medical condition like kidney failure, a urinary tract infection, or a head trauma or substance intoxication or withdrawal, medication use, or toxin exposure. It's an acute state of confusion with an underlying cause.
And then we have major and mild neurocognitive disorders, NCDs. What's the key difference in severity between these two? How does it impact daily life?
Major and mild neurocognitive disorders differ fundamentally in severity and their impact on everyday independence. Major neurocognitive disorder is diagnosed when there's evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. This decline is based on concern from the individual, a knowledgeable informant, or the clinician, and substantial impairment in cognitive performance, preferably documented by standardized neuropsychological testing. Crucially, these cognitive deficits interfere with independence in everyday activities, meaning the person needs help with complex instrumental activities of daily living, like paying bills, managing medications, or driving. In contrast, mild neurocognitive disorder involves evidence of modest cognitive decline from a previous level, again, based on concern and modest impairment in cognitive performance. But importantly, the cognitive deficits in mild NCD do not interfere with capacity for independence in everyday activities, though greater effort, compensatory strategies, or accommodation may be required. They can still manage their bills or medications, but it might take them longer or they need to use more reminders. The DSM-5 identifies 13 etiological subtypes based on the presumed cause, such as Alzheimer's disease, vascular disease, Lewy body disease, Parkinson's, HIV, traumatic brain injury, and so on.
Let's unpack Alzheimer's disease a bit more, as it's a key example and probably the most well-known cause of NCD that listeners will be familiar with. What are the typical stages of its progression? How does it unfold?
Alzheimer's disease typically progresses gradually, and thinking about it in stages helps understand the decline, though the boundaries can be blurry. The first stage, often called mild or early stage, commonly shows impaired memory, especially for recent events, like frequently misplacing things, forgetting names or appointments. There might also be trouble with complex tasks like planning a meal or balancing a checkbook, and sometimes subtle changes in mood or personality, like increased apathy or irritability. In the second stage, moderate or middle stage, memory problems worsen significantly. People may have trouble recalling both recent and more remote events. They might not recognize familiar family members or friends, and they often become disoriented to time and place, sometimes getting lost even in their own home. Language problems like word-finding difficulties become more apparent. They also experience more pronounced mood swings, possibly agitation or suspicion, and need increasing help with basic daily activities like dressing, bathing, or grooming. Finally, in the third stage, severe or late stage, individuals are severely impaired. They are profoundly disoriented and confused, may lose the ability to communicate verbally, might experience delusions and hallucinations, often have difficulty swallowing, lose bladder and bowel control, and require constant supervision and total care for all basic needs. It's a devastating progression that ultimately leads to death.
Yeah, truly devastating. Finally, we've arrived at personality disorders. These are distinct because they involve an enduring, persistent, inflexible pattern of inner experience and behavior. And this pattern substantially deviates from the expectations of the individual's culture, is pervasive across a broad range of personal and social situations, causes clinically significant distress or impairment in functioning, and is stable and of long duration, typically with an onset that can be traced back at least to adolescence or early adulthood.
Exactly. That enduring, pervasive, and inflexible nature is key. And for people under 18, a personality disorder can be diagnosed only if the particular maladaptive personality traits appear to be pervasive, persistent, and unlikely to be limited to a specific developmental stage or another mental disorder. And the features must have been present for at least 1 year. The specific exception is antisocial personality disorder, which, by definition, cannot be diagnosed before age 18. The DSM-5 distinguishes 10 specific personality disorders, and they're often grouped into 3 clusters based on descriptive similarities, which can be a helpful way to think about them, though there's overlap and debate about this structure.
Can you walk us through those clusters and maybe give us a quick characteristic for 1 or 2 key disorders from each, just to give a flavor?
Certainly. Cluster A disorders are often characterized by odd or eccentric behavior. This cluster includes paranoid, schizoid, and schizotypal personality disorders. For example, paranoid personality disorder involves a pervasive distrust and suspiciousness of others such that their motives are interpreted as malevolent. They expect to be exploited or harmed without sufficient basis. Cluster B disorders involve dramatic, emotional, or erratic behaviors. This includes antisocial, borderline, histrionic, and narcissistic personality disorders. Here, perhaps the most well-known is borderline personality disorder. Its essential feature is a pervasive pattern of instability in interpersonal relationships, self-image, and affects emotions, along with marked impulsivity. Think intense fears of abandonment, unstable relationships, identity disturbance, impulsivity in potentially self-damaging areas, recurrent suicidal behavior, affective instability, chronic feelings of emptiness, inappropriate intense anger, and sometimes stress-related paranoid ideation or severe dissociative symptoms. And cluster C disorders are characterized by anxious and fearful behaviors. This cluster includes avoidant, dependent, and obsessive-compulsive personality disorders. Note that obsessive-compulsive personality disorder is different from OCD. Avoidant personality disorder, for instance, is defined by a pervasive pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. They avoid occupational activities with significant interpersonal contact because of fears of criticism or rejection, are unwilling to get involved with people unless certain of being liked, show restraint in intimate relationships due to fear of shame, and view themselves as socially inept or inferior. This makes forming and maintaining connections deeply challenging.
Wow, that was a truly comprehensive deep dive into the DSM-5. We've covered, well, a huge amount from the foundational structure to the specific, often nuanced criteria for a really wide range of mental health conditions.
Understanding these diagnostic frameworks really is a crucial step, I think, in recognizing the complexities of mental health and
Yeah.
appreciating the diverse ways in which these conditions can manifest. It's about more than just labels. It's about having a structured approach to understanding human experience and the precision needed to try and help people effectively.
So what does this all mean for you, our listener? Consider how these diagnostic frameworks, while providing that necessary structure, also really encourage us to look beyond just a single label, to appreciate the unique tapestry of symptoms and life experiences each individual presents. It really highlights how much nuance is involved in understanding something as fundamental and complex as the human mind. So here's a thought to leave you with. What other areas of knowledge, maybe even outside of psychology, might truly benefit from a similar structured deep dive